create an effect.
I'm so sorry.
To create an effect. That's okay. So typically, you have a receptor bind or a molecule or a hormone or a protein bind to a receptor that usually causes phosphorylation inside of the cell on the inner portion of the receptor, and then stuff starts to happen. This is really the way that I think about it. I'm not one of the smartest doctors out there, and I really need to simplify this stuff for me to wrap my head around it. But basically, the receptor gets activated, and then lots of dominoes happen down the line. And inside each one of these little circles, so each one of these, like AKT, that's just a protein. All of these are just proteins. BRAF, I'm sure you recognize that. You probably run this test looking for this genetic mutation in urine. But even inside of these, there are multiple steps inside this little circle. So this is a very complicated process. But anyway, you eventually get your dominoes all the way down to the nucleus and tell the DNA to do something, make something, grow, divide, die. That's all this is. So you have this pathway, you have this domino effect telling the cell what to do. It does look a little more like this, and even this is probably simplified compared to what is actually going on in the cell. And when I first started studying these pathways, I was super overwhelmed. I was really like, I can't handle this. How am I going to use these drugs? I don't understand these pathways. There are so many steps, there are so many enzymes, there are so many targets and outcomes. And then I started learning about the drugs that target some of these proteins to stop the dominoes from falling. That is what targeted therapy does. It stops the dominoes from falling. I kind of got a little overwhelmed all over again because I couldn't pronounce some of these. Even now, I think I'm making up some of these pronunciations, let alone keeping track of, which drug targets which mutation. And this list isn't even exhausted. These are just some of probably a handful of the targeted therapies that I use. There are a lot more out there. But like every aspect of my professional training, and I'm sure yours, the more I read and the more I looked at things, the more comfortable I became. I mean, I was, and you are all already probably using some of these drugs, right? Apoquil is a targeted therapy. It targets JAK. Palladia or terceranib is a receptor tyrosine kinase inhibitor. And Cytopoint, it's an IL-31 inhibitor. So I bet most of you are using at least 2 of these drugs right now. These are targeted therapies. So to put it together, I find this illustration super helpful. This is from an osteosarcoma paper. It's a very simplified version of the previous illustrations without all the dominoes, but it tells the same story. There are transmembrane receptors. There are molecules that bind to those receptors and set off a chain reaction that eventually sends a signal to the nucleus. And it tells it to do something. Grow, divide, die, whatever. And in this illustration, the reason why I like this illustration so much is because you see a variety of receptors, and you see where the drugs bind to those receptors. So some of them bind on the outside, the monoclonal antibodies bind on the outside, the small molecules bind on the inside. Some of them will stop the pathway downstream of the receptor. In all of these cases, targeted therapy simply turns off the mutations that are driving the cancer to grow. So let's talk about a particular targeted therapy called. This drug blocks epidermal growth factor receptor and human growth factor receptor. Both are receptor tyrosine kinases, just like Palladium blocks a receptor tyrosine kinase. They're just a family of enzymes that catalyze cellular growth, proliferation, and survival. Trametinib also blocks the EGFR pathway, but downstream. So down here, lapatinib blocks it up here, trametinib blocks it down here. MEK is mitogen activated protein kinase. So why am I telling you about these two drugs in particular? It's because of this paper and others like it. So the BRAF or BRAF mutation is found in 70% of canine TCCs. BRAF is a serine threonine protein kinase in the mitogen activated protein kinase signaling pathway. I know that's a mouthful, but it regulates cell growth, proliferation, differentiation, and apoptosis. Canine TCC cells are sensitive to MAPK inhibition. In addition, the ERB-B signaling is upregulated in TCC cell lines, and the ERB or ERBB family of proteins contains 4 receptor tyrosine kinases structurally related to the EGFR. The ERB signaling is unregulated in TCC cells, so when you block this and MAPK, you can control TCC. When you use both of them, you get a much better effect. You get a synergism. So lapatinib is going to block these 2 receptors up here, which again are upregulated in TCC cells. Trametinib is going to block this pathway down here. So these are 2 oral medications that you can use in private practice to treat your TCC patients. Rebecca, are we good?
Yep. Mm-hmm. Got your screen up.
Okay. Okay. And what we're seeing is improved survival times when combined with IV chemotherapy. However, if all you do is lapatinib and trametinib, which is what I've been doing for several years now, we're seeing the same survival times as we did when we just used traditional IV chemotherapy, which you had to send a patient to an oncologist for. Now, I do think there are things that you need to know about these drugs and you need to have respect for them, but you can do this in your clinic. So let's see. It's been about 22, I have 22 minutes on my clock, so we can take a break.
Let's do that.
Okay.
That's a good place. Thank you. This is so exciting. I'm like typing away, taking notes.
Yeah, so. I love targeted therapy.
I'm such a nerd. So let's meet back. It is 28 after the hour. So let's come back. We'll do it even at 6 or whatever your hour is, wherever you are at 35 past the hour.
Okay. Or drugs, where, you know, I'm at the end, I'll talk about, I actually have a consultation service if you want like a detailed treatment guidance for your patients, but also happy to answer just a little like quick question about something. So you'll get my email at the end of this as well. Okay. Oh, we are 36. Okay. I'm still sharing my screen, right?
You are.
Okay, let me move the chat over. Okay. So let's talk about how we can put this into action for other types of cancer. So Seamus, aka the General, is a 12-year-old male neuter golden. He absolutely loves steamed veggies. I am not kidding. He was called a social butterfly, and he was diagnosed with a poorly differentiated malignant oral neoplasia. He also had 2 metastatic lymph nodes. I don't know if you all love that diagnosis as much as I do. Poorly differentiated cancer. Like, thanks, I already knew he had cancer. Thanks for the help. So back in the day, before we were able to perform a genetic analysis and use targeted therapy for patients, this is a patient that I probably would have given, you know, some tramadol and an NSAID to, and, you know, go with your creator. So this is what he looked like in November of 2021. This was after a biopsy. So he had this ulcerative and proliferative red gingival mass in the upper left quadrant. He was very resistant to oral exam. The longest measurement was about 3 centimeters. And when you looked at him, you know, just from across the room, you could see this bulge under his eye when his mouth was closed. So we did order that pathology where we got cancer, but we also ordered a genetic analysis. A DNA analysis will tell you which mutations are present in a particular cancer. In his cancer, in his tumor, he had 4 mutations, 2 of which were targetable with drugs. So I say we, like I do this, the labs are able to test for a lot of mutations. There are a lot of mutations in cancer. They're not all targetable with a drug, and not all mutations are driving the cancer to grow or to spread or to do stuff. So not only are some of them not targetable, some of them we're not even sure what they do. So you might get a report where you see a bunch of mutations, but no drug recommendations. Luckily, he had 4 mutations and 2 of which were targetable. Both of them were in the NRAS family. NRAS belongs to a class of genes known as oncogenes. They encode proteins that play an important role in cell division, cell differentiation, and apoptosis. Activated NRAS mutations lock the enzyme in an active state, causing increased cellular proliferation, cancer. Luckily, trametinib can block the NRAS pathway downstream at MEK. So we put him on trametinib. So this is what he looked like in November of 2021. January of the following year. You can see it, you can still see ulceration there, but it looks much better. And then in June, you couldn't see anything. Now, this was one of my first cases that wasn't TCC that I used targeted therapy for. He had a beautiful response. And back then, I'll speak for myself. I didn't really know how long I should be treating patients. There are some oncologists who treat for life. I'm not sure I will ever be in that camp. Maybe with more data for sure. But I treated him for 6 months. Because that's how we treat a lot of cancers. We treat for 6 months, we treat lymphoma for 6 months, I'll treat some mast cell tumors for 6 months, and if we're in remission at the end of the 6 months, then we're gonna take you off your chemotherapy and monitor you. So I stopped his therapy after 6 months, and in September of 2022, his cancer came back. And when I restarted treatment, he seemed to be resistant to it. He was not responding, and he had cancer in multiple places by then. And then he was euthanized in October. But malignant oral neoplasia, a few years ago, he probably would have been euthanized in December of 2021. And so he made it almost a year after his diagnosis. And he was an awesome dog. I mean, he was huge. He was this huge, long golden retriever, a lot of skin hanging off of him. And he would come into the clinic just barking his head off until we gave him all the steamed veggies. His mom would pack his little snacks with him. She would bring a Tupperware of steamed veggies that we had to give him during his treatment. And he knew they were there, and he would bark and bark and bark until we gave him all the steamed veggies. Seamus was a lovely dog. On to immunotherapy. So immunotherapy is defined by cancer.gov as cancer treatment that helps the immune system fight cancer. So there are a lot of different types of immunotherapy. There are immune checkpoint inhibitors, T-cell transfer therapy. T-cell transfer therapy is really cool. I think there's only like one university doing this in dogs, but they do this in people. So basically, what they do is they take off either all of the tumor or a piece of the tumor, and they find the T cells that are most active against the cancer. They kind of harvest them out or dig them out and like separate them and then grow them into thousands of cells, probably millions of cells, and they give them back to the patient to go after the cancer like little soldiers. So cool. Monoclonal antibodies and treatment vaccines. Monoclonal antibodies can mark cancer cells to kind of be as a little beacon for the immune system to see. So they stick to the cancer cells and they say, hey, you need to destroy this. Immune system, come destroy me. That's what monoclonal antibodies do. Treatment vaccines, these work against cancer by boosting the patient's immune system to respond to the cancer cells. The melanoma vaccine is one of them. We are going to talk about that. Autologous cancer vaccines, which are available to you. And then immune system modulators, that's kind of a broad term. They enhance the immune system's ability to respond to cancer. And that could be something like the beta glucans in mushrooms, which we're also going to talk about. So that is considered an immune system modulator. So although the melanoma vaccine is not really available to general practitioners, I do know some general practitioners who have got their hands on it, and I still get a lot of questions about it. So I did include that one in here. It's a little bit of a cheat. So this is human. What the melanoma vaccine is human DNA that encodes for tyrosinase. Tyrosinase is just an enzyme that is found in melanocytes, which are the cells that give us our pigment. Tyrosinase is essential in melanin synthesis, and I shouldn't say usually, in a lot of melanomas, you'll see an upregulation of this process. Luckily, there is cross-reactivity so that the dog's immune system recognizes the human tyrosinase as foreign, and it starts attacking those cells expressing human tyrosinase. But because of the cross-reactivity, it also starts attacking any cells that are expressing canine tyrosinase. So it's different enough to signal to the immune system something's wrong, but it's the same enough that the immune system attacks both. That's how the melanoma vaccine works. This is offered to most dogs with melanoma, certainly oral or digital. Some cutaneous melanomas I will also offer the vaccine to. It is a transdermal intramuscular needle-free injection, kind of like the FELV vaccine. And then we give this every 2 weeks for 4 treatments, and then we booster it every 6 months. The company Boehringer Ingelheim, they only sell that vaccine to oncologists, so it's not something that's easily accessible by general practitioners. However, another form of immunotherapy called an autologous cancer vaccine is available to general practitioners. Cancer.gov, love cancer.gov, defines autologous cancer vaccines as a therapeutic agent produced by isolating tumor cells from an individual and processing these tumor cells into a vaccine formulation in vitro. The vaccine is then administered to the patient from whom the tumor cells were isolated. So you take them out, you do something to them, and then you give them back to the patient to try to ignite the immune system. So an autologous cancer vaccine should include mutational epitopes that are synonymous with the patient. An epitope, in case you don't know, because I didn't know, I had to look it up too, is the part of the antigen molecule to which the antibody binds. So the antigen is a whole molecule, woo, it's really big. But there's only one little part that the antibody binds to. That's the epitope. That's really important. You want your antibodies to be able to bind to that so that it calls the immune system over to start attacking that cell. Autologous cancer vaccines also include a range of targets, not only the tumor cells, but the extracellular matrix. The extracellular matrix is the capsule or the force field around the tumor, so you want to be able to attack that too. Oh, can you turn off your camera? Me? Turn off my camera?
Yes, if you can. I just want to
Sure.
see sometimes there's some glitches.
Okay, let's try that. And you can put in the chat if it's working or not. And it's good because now I can't see my face, which was very distracting. Autologous cancer vaccines provide an exact in vivo replica of mutational epitopes. So, do they work? Well, yeah, they work, but just like with the melanoma vaccine, it seems to work for some and it doesn't work for others. And we don't know who's who ahead of time. The nice thing about this technology is that it's applicable across tumor types. It can be used for any species. We're using this in dogs, cats, horses. And I have yet to see a serious negative side effect. We do monitor the patients for like 15 minutes after we give the vaccine. And I've seen a couple of times a patient's temperature has increased. Some of those occasions, the dog was running around outside because, again, I'm a mobile clinic. The dogs go back to the car, go back to the owner. The cats are sitting in the car, so it's possible that that was due to the vaccine. Maybe some of it wasn't. The company that makes it, who we're going to talk about, they do talk about, having a very serious potential allergic reaction to the vaccine. I personally have yet to see that or hear about it. I'm sure that it could happen.
Dr. Rizzo, you touched on some side effects, but we had a question about the most common side effects and maybe any additional real life experiences that you had using those.
Yeah, so, and someone's also saying my personal pet had one, and I think she was tired on vaccine days, but otherwise was fine. Yeah, so, I have seen some elevated temperatures after the vaccine, in that 15-minute window. I think now that this person is saying that, I think I had a cat patient once whose family told me she seemed really tired after the vaccine. But other than that, I'm not really seeing negative side effects. Now, I've been using the Torsion vaccine for maybe 4 years now. Maybe, after we use it for a lot longer, maybe we will see some other side effects, but I think the biggest side effect really is to the client's wallet. It's not really that expensive, but it's expensive compared to prednisone for sure. So Torsion is the company that I use. They make a tissue vaccine. It includes the tumor cells, it includes the extracellular matrix, and they are very proud of the fact that they do not use in vitro culture or enzymatic degradation. Their scientists feel that this can interfere with the immune system's ability to recognize those tumor cells. Leslie, can you still hear me? You can just put it in the chat.
I can.
Okay, the videos all disappeared and I thought everything disappeared. Okay. So the reason that the Torsion vaccine might be working is because of the matrix immune modulator. So, when I first started thinking about this and when I first heard about it, I was like, I don't understand. You're taking a tumor off and you're putting it in a blender and turning it into a mushy liquid and giving it back to the patient. So what? It was already there. But the step that I was missing in my head when I first learned about this is that they are attaching an immune modulator to those cells to ignite the immune system, to alert the immune system that these cells need to be attacked. And that immune modulator is porcine small intestinal submucosa. So there are no metals. This submucosa combines with the cancer cells and the extracellular matrix antigens, and it will hopefully trigger an immune response. This is an early paper that was written by the folks, the scientists at Torsion who are working on this technology. A lot of papers in veterinary medicine aren't perfect. This paper certainly is one of them, but it was still very interesting. So they looked at using the cancer vaccine for canine patients with metastatic hemangiosarcoma. And so they compared patients who had just surgery and nothing else, and some patients had surgery and the Torsion vaccine. And what they saw was that patients who had the Torsion vaccine had the same survival time as historical controls that received surgery and chemotherapy, which, that was pretty interesting to me. Again, it's not a perfect paper and it's not that long of survival time, but hemangiosarcoma is a terrible, terrible cancer. And if you already have metastatic disease, I'm going to be very blunt. Your patient will no longer be with us in a month. So to see a survival time of 142 days with this vaccine, that was interesting enough to me to try it. The other paper that they have put out is a safety experience with this vaccine in cats. So they treated 117 cats. They had biopsies or surgical excision. 438 vaccines were administered, and 5% of them had adverse reactions. Some were injection site swelling or lethargy. The question is, can you try the biologics with any kind of metastatic neoplasia? Yeah, you can try the Torsion vaccine with any kind of tumor. If you can get a chunk of that tumor off that's about the size of a kidney bean, you will be able to use this vaccine. Now, one thing about immunotherapy is it can sometimes take the immune system a while to figure out what to do with this stuff. So it could take a few weeks For the melanoma vaccine, those researchers say it could take 2 to 3 months before the immune system actually starts going to work. So if you already have metastatic disease and it's bad, it's possible that the vaccine won't work fast enough to overcome that. But again, very unlikely to have side effects. And, you know, if family is willing to do it and they understand that when it comes to cancer, sometimes what we do works and sometimes it doesn't, I say go for it. So this is an example of the Torsion vaccine being used in a horse for a sarcoid. I don't know if anyone out there is doing large animals. I don't know much about horses. I do know that if you can get a sarcoid off, you can usually cure that horse. But as you can see in this photo, this is not an easy area to do surgery. So they debulked about 10% of this tumor in August of 2022, and they gave the Torsion vaccine. I think horses get 6 injections, not 3. And in October of 2022, you can see that it looks a lot better. So that's pretty cool. This is not my case, but this is a case of an 11-year-old male neutered Siamese cat with mammary adenocarcinoma. This cat went through a lot, had surgery maybe in 2016 for a mammary mass, did nothing beyond surgery. Then a couple years later, mammary mass came back and chest x-rays showed this metastatic disease. They went ahead and removed one of the mammary masses to create the vaccine, only treated this cat with the vaccine, and 2 years later, this is what this cat's lungs look like. That's bananas. Metastatic mammary adenocarcinoma is a wretched disease, and if you do nothing, you will be gone in about 6 months. This cat was treated with just the melanoma vaccine, and the metastases, you can still see them, but they are a lot smaller and there are a lot fewer of them. And that cat did very well. Someone is asking me if I combine treatments. We are going to talk about that. This is Mork. Mork is a 12-year-old male neutered mixed breed dog. He had this mass on his face. We biopsied that in May of 2021. And I like to ask the audience what they think this is. I usually get answers like soft tissue sarcoma, osteosarcoma, mast cell tumor. I've been giving this talk for a couple of years. I've done it several times. Only this year at one event in Alaska did someone say hemangiosarcoma, and they were right. So he was diagnosed with this subcutaneous hemangiosarcoma on his face. We did that histopathology, and we also did a genetic analysis, and he was found to have a BRCA1 mutation. Patients with a BRCA1 mutation can be treated with olaparib or olaparib. Like I said, I don't know how to pronounce all of these. Oh, I don't know where my picture is. This is a PARP inhibitor. PARP stands for poly ADP ribose polymerase. This is just the DNA damage repair enzyme. So olaparib can kind of turn off this process where the cancer cells are able to basically keep fixing themselves. So he was treated with olaparib and the Torsion vaccine. I should also say, while we waited for his genetic analysis, which takes about 3 weeks to get back, we did give him a dose of doxorubicin because doxorubicin can be a good drug for hemangiosarcoma, albeit it rarely works against gross measurable disease. But I was like, I got to do something. This mass is growing out of control on the side of his face. It did nothing. The doxorubicin did nothing. I think we also tried some metronomic chemotherapy, so low doses of oral chemotherapy are supposed to cut off the blood supply to the tumor and shrink the tumor that way. That didn't really do anything. So we then gave the Torsion vaccine, and after those 3 injections, we had our genetic analysis back and we started the olaparib. So this is what he looked like in May of 2021. September of 2021, I hope you can appreciate that it's smaller. This is the best we did. So this is the most reduction in size that we saw. That was in November of 2021. And it stayed that way for a while. He eventually became resistant to these drugs. We tried increasing the dose. I can't remember if I tried another drug. I think I just tried increasing the dose. But I think it was June, it was definitely summertime of 2022. That's when he finally, like the last 2 weeks of his life, you can tell he was really uncomfortable. He was unhappy. He wasn't acting like himself, and we did end up euthanizing him. But for hemangiosarcoma in an area where surgery just, isn't going to cut it, and we know that traditional IV chemotherapy doesn't really work against gross measurable hemangiosarcoma, I was like, well, I got to try something else. And luckily these owners were up for everything and anything. We even boosted his Torsion vaccine because it was after COVID, people were getting boosters, and the owners were like, should we booster it? And I was like, I don't know. I'll call Torsion and see if they have extra material, and they did. So we did booster his vaccine about 6 or 7 months after the initial series, and he did really well for a long time. Mark was a really fun dog, and his family really loved him, and were really bonded to him. So it was sad to see him go, but we were really happy for the time that he got with his family. So I want to stress that I know that, I've talked about a few things here that may be a bit new, and it might be a little bit overwhelming to think about combining these things and treating cancer patients on your own. But you're not alone out there. We're here to help you. I love to say that cancer sucks, but there's hope, and there's us. We offer telehealth guidance for general practitioners wanting to take care of cancer patients in their clinic for whatever reason. Most of the time it's families don't want to go, can't go to see the specialist. And, then you're left trying to do the best you can to help these patients. And I get that. I'm very passionate about the fact that there is more than prednisone and tramadol that you can do for these patients. And I would love to help you do it if you think you need a little bit of guidance. So this QR code is how you can reach me. I will put my email address at the end. We still have another about 45 minutes to go, but it's been about 20 minutes, so we're going to take another 5-minute break.
Thanks so much. So let's come back after, let's do 8 after the hour, or I'm sorry, 9 after the hour. Does that work?
Yep, sounds good.
Perfect. All right, we're getting close to 9 after the hour. So we're going to get started back in a minute.
I'm back, Leslie, can you hear me?
I can. Welcome back.
Sorry, I had to talk to my Aunt Dee for a second.
I get it.
Okay, I'm gonna stop my video. Okie dokie. Okay, part 2. Okay, I can see the chat now. So can anybody tell me what this is? What type of cancer is this a cytology of? Oh yeah, this is a mast cell tumor. These are nasty little critters. So I'm sure you've all heard from the pharmaceutical companies trying to sell you this stuff, Tigilanol Tiglate. This is also called Stelfonta. This was also very scary to me when I first heard about it and saw photos. I nearly jumped out of my skin. But like I said in the beginning, like everything else, you just kind of digest it, read about it again, and then just have confidence that, you know, you can do this. So Tigilanol Tiglate is a diterpene. This is a class of chemical compounds composed of 4 isoprene units. Isoprene, or 2-methyl-1,3-butadiene, is a common organic compound with this formula, CH2, blah, 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 blah. If anybody's, I probably should have made an announcement. If anybody has PTSD around organic chemistry, we are going to be talking about organic chemistry. I'm very sorry I did not announce that ahead of time. I kind of loved organic chemistry. It just made sense to me. This compound is interesting. In its pure form, it is a colorless, volatile liquid, but it is produced by many plants and animals, including humans, and its polymers are the main component of natural rubber, which just fascinates me. Like, how you figure out you should inject that into a mast cell tumor, I have no idea. So this is what it looks like in the bottle. It's from Burback. It is a potent cellular signaling molecule. One of its mechanisms is to activate protein kinase C. Intratumoral injections of tigilanol elicits a rapid but highly localized inflammatory response. It disrupts tumor vasculature. It induces tumor cell death by oncosis, and these processes lead to hemorrhagic necrosis and destruction of the tumor within about 2 to 7 days. And this is followed by resolution of the wound within about 28 to 84 days after treatment. So pretty interesting stuff. Verback says that Stelfonta should not be injected into subcutaneous mast cell tumors located above the elbow or hock, as this may result in accumulation of necrotic debris in the subcutaneous space, increasing the risk of systemic adverse reactions, including death from mast cell degranulation. Luckily, I haven't had that, but we're going to talk about some nasty reactions that I did see. Virbac has kind of changed their marketing a little bit. That looks a little bit blurry. Oh, there we go. But this is what they used to show when the medication originally came out. So this is pre-treatment of 3 different tumors. 15 to 24 hours later, you start to see it swelling up. I mean, we see this literally like as we're injecting it, we see the tumor swelling up, it getting red, it kind of changing colors. So you can see that here with these 3 tumors. And then another few days later, this is definitely very similar to what I was seeing when I first started using this medication. So the tumor kind of like dies and kind of like pulls away from the body, becomes necrotic, just kind of falls off, or it's gross to think about, but maybe it gets eaten. So disgusting. Sloughs off, and then underneath you have this very pretty bed of granulation tissue. So the immune system has already started going to work from day 1, and when the tumor falls off, the body is already starting to heal itself, which I think is really cool. And then a month or 2 later, it should look pretty normal. So this is an example of one of the dogs I did. This was the first dog that I ever injected. This dog belonged to a lawyer who worked from home. He wanted to do anything and everything he possibly could for his dogs, and we talked about this medication months before it was available, and he did not want to amputate this dog's leg, and he waited for this injection to be available. We started the pre-medications that they recommend, which is Benadryl, Pepcid, and prednisone at 0.5 mg per kg per day, 3 days prior to the injection to fight degranulation, because it's very possible that once you inject this tumor and make these mast cells very angry, they are going to degranulate, and that can cause a lot of problems. So we did this. Oh, the other thing is that when this stuff originally came out, they were like, oh, it's just like any subcutaneous injection. You don't need any pain control. You don't need any sedation. And I was like, okay, cool. No, that was a big mistake. This dog immediately started pulling away her leg, trying to get up. I mean, it was clear that what we were doing to her was very uncomfortable. And so that kind of stunk. So I don't do that anymore. I definitely give pain control and sedation. And it's a lot easier, even though this is a quick process, it is so much easier to spread the Stelfonta around the tumor with a sedated dog rather than a dog that's trying to jump off the table. So we did this injection. This was her 7 days later. Kind of just like the pictures. What I'm not sure you can appreciate is there's kind of a lot of swelling in her leg. This actually looks better than it did about 2 days later. So 2 days after the injection, her leg was swollen from paw to hip. This owner was beside himself. She couldn't use her leg at all. He rightfully said he was not prepared for that. I was not prepared for that either. I kind of tried to play it off like, yeah, this is what happens. I now warn people of that. She also would not stop licking this, and Virbac tells you that you do not need and shouldn't put an e-collar on these patients. You should not prevent them from licking the wound. In the studies that they did, the dogs that were prevented from licking the wound had delayed healing times. But she was licking it and driving him nuts while he was on, Zoom meetings with his clients. So we did sometimes put an e-collar on her when it was driving him crazy or when he needed to get some sleep. But this is what it looked like day 7. This is it on day 14, looking real gross. I mean, this is granulation tissue under there, but I am not a surgeon. I am not an ER doctor. I do not deal with wounds, and this definitely grossed me out. This was traumatic for everyone involved. But this is what it looked like day 30. Someone's asking if you should bandage it, and the company says no. Do not bandage it. You need to leave it open to the air. And they think that when the dogs are licking it, it's actually stimulating the immune system even more. So they say no bandages. They don't say no bandages. They don't say no e-collar. They suggest against it, but they tell you to use your judgment. But this is on day 30. This is the last photo that I have of her. But this wound healed up very nicely. Her leg is functioning. It took her about 2 weeks, I think, to not feel painful and to not feel like we needed to be giving her pain meds twice a day, every day. So that did resolve. The wound resolved. She got to keep her leg. The mast cell tumor is gone. So technically it is a success. I just now prepare people differently for it. Now I kind of go overboard with how nasty and disgusting these things can become. And I definitely give sedation and I definitely give pain meds. This is another one that I did. This is a bit of an embarrassing story, but I'm going to share it with you. So hopefully you learn from it. So this little lady here, she had this mast cell tumor on her toe. So I'm sure you've all seen one of these. You know, this is not an easy tumor to remove. You'd have to remove both of these toes. They're not the toes that you want to be removing and have a functioning leg left. So we talked about amputation. However, you know, while that will cure this tumor, and it's not wrong to do that, she's a Boston Terrier and they get mast cell tumors. And there's a very good chance, there's a 30% chance that this will not be her last mast cell tumor, even if this is low grade. 30% of dogs with mast cell tumors will get another one at some point in their lifetime. So we could amputate this, but she's likely to get another one and you will have to deal with that as well. But the owner really wanted me to give this injection. She knew about it before she came to see me. She knew about the Stelfonta and that's what she wanted for her dog. And I was like, look, lady, this is right near the bone. Like there's not a lot of skin there. There's not a lot of sub-Q stuff going on there. This is a big tumor. You know, this is going to get really ugly. It's going to become an open wound. It's going to get nasty. It's going to be oozing. It could get infected. And she was like, I got this. And I was like, okay. So we put her on Benadryl, Pepcid, prednisone. I also put her on pregabalin. We'll talk about that later. That's one of my favorite pain relievers. And I did sedate her for the injection, and it was very nice to have a very still dog while I injected this tumor. And right away, you saw it blowing up and getting red. So this is what happened to her a few days later. Her whole arm swelled up a few days after that, got really red. It's possible this is an immune reaction. It's also possible this is degranulation as well, really making things angry. So we injected her on April 26th, and this was her on May 3rd. So yes, that is her bone. And as I mentioned, I am not a wound manager, and this definitely scared the bejesus out of me. And looking back, I would have bandaged this, but I did not at the time. They said, don't bandage it. You know, I kind of had that on one part of my brain. The other part of my brain was like, that's a bone, like this is not right. So I put her on antibiotics. We put her, I mean, she was using her leg. She did not seem to care about this for some reason. And a month later, it was pretty healed. In between that month, or, during that month, we brought her in every week. We did take x-rays of that. We did see inflammation of the bone for sure. And then after it healed, it kind of became crooked, and the owner thought it was broken, that the bone was broken, but we took x-rays of it again. It was not broken. What I think happened, the Stelfonta not only killed the tumor, this is just my theory, not only killed the tumor, but weakened the ligaments. I think the ligament broke. It is permanently crooked now. And I think the Stelfonta destroyed the nerves, because she was not painful at all. She was using her legs, she was running around, using her life, or living her life, which just boggled my mind. So I figured the Stelfonta murdered everything that it touched in this dog. So that was her. That was very scary. Verbac now does a better job of warning people that this can happen, and that bad things can happen, and that legs can swell up like that. And even though I had these 2 experiences, I still use Stelfonta. Again, I am overly explanatory when it comes to client education now with it after that first experience. I'm not sure I will ever do one this close or on a digit again. I don't know. Maybe I'll, instead of giving the recommended dose, I'll back off a little bit. I think if I ever, God forbid, have an exposed bone again, I will bandage it. So, I will do things differently, but I have been using Stelfonta since both of these experiences, and some of the tumors, sometimes you can still see an abnormality in the skin, you can still see a lesion, but they just kind of flatten out. And and they don't get the redness, they don't get black, they don't fall off. But when I aspirate them several weeks later, I can't find any mast cells. And Verbac is now reporting that a lot of people are reporting those experiences as well. One of the questions is, how do you differentiate doing that injection versus removing the mass with surgery? Is it dependent on where it is and if it's a difficult spot? Absolutely. So it's dependent on whether or not that patient can even have surgery. So a lot of my patients are geriatric, they have other problems. Maybe they can't have surgery, but maybe their owners just don't want to anesthetize them. So that gets factored into it. And then certainly, if it's in an area, most of these tumors that I'm injecting are on the lower limbs, in areas where we're not going to get a clean excision. So I also warn families that, if we do this, I can't grade the mast cell tumor. Now, you can get cytologic grading now. There are pros and cons to that. I'm pretty sure there's only one paper on it. But it is something, and I do stage the patients. And then if there's no evidence of metastasis, I warn the owner, I'm like, look, I can inject this. Roughly 60 to 70% of mast cell tumors are low grade. So if we can cure it with Stelfonta, you will probably be done with it. But I'm warning you, we can't grade this. And I think, because of that, now we need to restage your dog, in my opinion, every 3 months for the next year. So I would not necessarily do that with a low grade mast cell tumor. So, and not that families have to do that, but that's my recommendation, because God forbid we do find metastasis at some point, I'm putting that dog on medications. What about a mast cell tumor that has metastasized? Yeah. Would you use the autologous vaccine, or is there another biologic? That's a great question. I've only used the Torsion vaccine for one mast cell tumor case, and that was with a family who did everything that they could as long as she was feeling okay. And we did try the vaccine in that dog. I would like to try the vaccine for more dogs with mast cell tumors, especially those dogs who have multiple mast cell tumors. I do tell families, and I tell general practitioners, you get to a point where you're just playing surgery whack-a-mole with these mast cell tumors, and the terrible thing is that even in those cases where there's multiple mast cell tumors, it's not like chemotherapy is necessarily going to help them. It's not like targeted therapy is necessarily going to help them. It might, but most of them are multiple low-grade mast cell tumors. And low-grade mast cell tumors don't respond very well to chemotherapy or targeted therapy. So I think trying the Torsion vaccine for dogs like that is a great idea. How do we feel about a small incisional biopsy for grading prior to or during the same appointment as the Stelfonta injection? That is a great question. You don't even want to aspirate the mast cell tumor prior to a Stelfonta injection. And you definitely don't want to biopsy it prior to a Stelfonta injection. You want the tissue to be as intact as possible. You don't want any of that stuff leaking out. And doing a biopsy prior to an injection, you'd probably have to wait, I don't know, at least a month before you could inject it after the biopsy. Especially for those mast cell tumors that really don't like to heal after you mess with them. With a biopsy, it can take weeks to heal. During that time, it could still be growing. So unfortunately, doing a biopsy prior to injection is not advised. I know it's annoying. You can do an FNA like a week before the injection. You can request grading on the cytology. You have to request it. Pathologists won't just do it. That's my understanding. So I do get some reports where I feel like they did try to grade it via cytology and I didn't ask for it. So I was not aware that you had to specifically ask for it, but the company Verbac has said you often have to specifically ask for grading via cytology. So yeah, no messing with it on the day of the Stelfonta injection. That should be the only thing that you do that day. These are really good questions. I know yucky pictures often get pretty good reactions. I am at a point where, oh, another question. I have a patient that has a cutaneous mast cell tumor on the face with lymph node involvement, older client, so wondering what the options are that client can handle as well as the dog, other than do nothing. Oh yeah, you should email me. There's a lot of things I think you could do for that dog. If they can get pills into that dog, that would be helpful. I definitely wouldn't inject Stelfonta anywhere near anybody's face. And I wouldn't use Stelfonta for a metastatic mast cell tumor. I would definitely use oral medications. I would consider doing the Torsion vaccine if that lymph node is easily popped out. So to speak. You could do that. There are several drugs that are potentially effective. There's a targeted therapy drug called imatinib. If you want to email me after this, I can give you more information about that, but there's a very good chance that dog will respond to a tyrosine kinase inhibitor like imatinib. And as long as the family can get oral medications into the dog, it's very possible that you can help that dog for quite a while. Not a guarantee, no guarantees in oncology, but very possible. Okay, Leslie, I am at a point where we can take a break and then we can finish it up when we get back.
Sounds good. So it is 32 after the hour. So let's just make it even and do it at 40 after the hour. So 20 till.
Sounds good, Leslie.
Thank you. It looks like we're in the home stretch, everyone. Thanks for sticking with us. It is almost 20 minutes to the hour. So this has been great. Like, I'm a crazy person taking notes and think this is amazing. So I don't usually have a 2-hour CE that I'm like, oh my gosh, it's almost over. Like, I feel like the time has flown by. So thank you so much, Dr. Rizzo. This has been great.
Oh, my pleasure. Okay, are we ready?
Yeah, we can go ahead and get started.
Okay, I'll turn my camera off again. Okay. Okay, like Leslie said, we are in the home stretch. We're going to be talking about some complementary therapies that I use for a lot of my patients. So complementary therapies are basically everything that isn't direct cancer treatment. So acupuncture, bisphosphonates, which I hope after this talk, everyone will be very excited to use bisphosphonates, supplements like CBD and mushrooms and melatonin, oral pain relievers, diet, everything on this list I do except acupuncture. I'm not trained in acupuncture, but I do think that it helps some patients, and I do think it has its place. Bisphosphonates are something I use a lot. So these are drugs that specifically inhibit osteoclastic activity. They are standard therapy for a variety of diseases in human patients, anything that causes bone resorption. So osteoporosis, Paget's disease, primary and secondary bone tumors. Almost every patient with multiple myeloma in human medicine gets a bisphosphonate. And then we can also use it for paraneoplastic hypercalcemia. So bisphosphonates work by attaching to the hydroxyapatite binding sites on bone surfaces, especially surfaces undergoing active resorption. When osteoclasts begin to resorb the bone that is full of the bisphosphonate release during resorption impairs the ability of the osteoclast to form this ruffled border here, which is what you need, which the osteoclast needs to stick to the bone and start sort of eating away at it. Well, there's some other chemical stuff. We don't really need to talk about that, but bisphosphonates are amazing. And this whole process of bone physiology is also, I think, quite fascinating. So if you remember from veterinary school, you have this constant dynamic of osteoblasts and osteoclasts, and the osteoblasts build up the bone, osteoclasts destroy the bone. And then depending on how you sort of bear weight and, you know, the sort of physics of your bone, sometimes the osteoblast will build up bone on one side of the femur and not on the other side, and the osteoclast will come and kind of like make that part thinner. It all depends on how you bear weight on your bones. But also, as we know, the bone holds all of your calcium. And so when you need more calcium, the osteoclasts are told by your parathyroid hormone to get to work and start releasing that calcium. What happens in cancer is that, so two things. So for bone tumors, you just have osteoclasts being upregulated and activated by tumor cells, and that's why you have holes in your bone, and bisphosphonates can stop that process. And then in any tumor that is basically causing hypercalcemia, that is because the tumor cells are releasing parathyroid related hormone. So it looks like parathyroid hormone, and this is a chemical that's being produced by the tumor cells that signals the osteoclast to start destroying bone and releasing calcium. So too much calcium in your blood, as you all know, is terrible. So if you have a paraneoplastic hypercalcemia, or if you have a bone tumor of any kind, if you have bone lysis, you can use zoledronate to help this patient. Zoledronate is a bisphosphonate. It's IV. The dose is 0.25 mg per kg. You can go down to 0.1. I try to go as close to 0.2 as possible. You'll reconstitute this for a big dog in 100 mils of saline and give this over 15 minutes. If you have a really tiny dog, maybe you'll only do 30 mils. Repeated doses of zoledronate can be hard on the kidneys. This is particularly true if you're not diluting it in saline, but you still want to evaluate kidney function prior to each dose of zoledronate. Zoledronate is an irritant, so it's not a vesicant, it's not chemotherapy, it's not going to cause necrosis of the skin, but if you get it outside of the vein, it can be very irritating. So for any irritant, and especially for vesicants, I do not recommend putting them on a pump and putting them in a cage and walking away. I have my nurses sit with the patient the whole time, watching the infusion and making sure that we're not getting any leakage. Zoledronate can be given once every 2 weeks. Sometimes you only need to give it once every 6 weeks. So both for bone pain and hypercalcemia, you give the dose and then you monitor the patient. For hypercalcemia, you might not see its maximum effects for a full 2 weeks. So if you check a calcium level 2 days later, it might still be the same. Don't give up on it. I wouldn't check it for about a week, and then I would check it again a week after that and see where you're at. And then I would keep checking it once every week or two until you figure out when it starts to rise again. And that's when you know to give the zoledronate. Alternatively, you can just give it every 4 weeks. I do that for a lot of my patients. Also with bone pain. So I once had a client, this probably happened to me 2 or 3 times now, where they knew when the zoledronate was wearing off and that the patient was due for the dose again. And for one patient, that was at 6 weeks. At 6 weeks, she became painful again. We gave the zoledronate and she felt better. So you can give this drug once every 2 to 6 weeks. For a lot of patients, just for ease, I just give it once every 4 weeks. If the family can do it, that's what we do. And you can use zoledronate with just about any other pain reliever. So if you have a dog with a bone tumor and the family won't amputate or the patient is not a candidate for amputation, you want to be giving oral pain relievers, but I also strongly recommend that you give zoledronate as well. So, cannabinoids. These are chemicals that act on the cannabinoid receptors throughout your body and throughout almost all mammals' bodies. This is a diverse chemical or diverse class of chemical compounds that act on these receptors, and they alter the neurotransmitter release in the brain. The ligands for these receptors are proteins that include the endocannabinoids, the phytocannabinoids, and then synthetic cannabinoids, which are manufactured artificially. I don't know if this is accessible everywhere in the country, but shortly after I moved to Washington, it became legal, and then every client was asking me about it. And when I first moved to Washington, I was straight out of my residency, and again, I had that kind of ivory tower mentality, and for the first year, I just was like, can't talk about it, we don't know enough about it, it's just a supplement, blah, blah, blah. You should really use these other drugs instead. But I got tired of hearing that from myself. And so I started doing some research on cannabinoids and CBD in particular. And there's actually, there is a lot of research out there. On the one hand, the government makes it difficult to research this because the federal government still classifies CBD as a class 1, whatever it is, it's the same as heroin, which is just ridiculous. And anything that has that schedule, like heroin, it's difficult even for researchers to get their hands on and do good quality research. That being true, there are a lot of papers out there looking at cannabinoids and how they can help patients, human patients with seizures and with inflammatory conditions and side effects of chemotherapy. I mean, there's just a wealth of information out there. But what gave me permission to finally use cannabinoids in my practice was a study that came out of Cornell. And they looked at using a particular concoction that included CBD along with other terpenes from the hemp plant. And I think that product also has, I think it's glucosamine in there. But they looked at dogs who had refractory arthritis. So these dogs were no longer responding to all the typical arthritic medications that we have, the pain relievers that we have. This was before Librela and I think before Adequan. And for a lot of dogs, they saw relief for those dogs. So because Cornell said it was okay, I was like, okay, great, I can use this product now. So there are a lot of CBD products on the market, like a lot. And when I started doing my research on this, I started looking at a few things that I want to see in a product. The first is that I want to know how that CBD was extracted from the plant. There are a lot of ways to get that chemical out of the plant, and you want a product with a clean extraction process. So that usually means using carbon dioxide to get the CBD and the other terpenes out of the plant. Another way to do it is to use alcohol or butane or ethanol. You don't want those. And so if the product that you're looking at doesn't say how the CBD was extracted, then you don't want that product. I also have noticed that, especially in pet care, but probably also at the dispensaries for humans, sometimes it's not clear how much CBD is in a milligram or a milliliter, or sometimes even the whole bottle. But sometimes all you'll get is what's in the whole bottle. So if you get like a bottle of liquid and there's CBD in there, it might say there's 30 milligrams in this bottle. Well, it's really hard to then tell, like, well, how many milliliters should I give? I mean, you can do the math, but some of these products don't even say that. They just say CBD on there. So if it's not clearly stated how much is in there, how much is in the pill, how much is in the milliliter, then I wouldn't use that product. There are a lot of good products out there. This is certainly not an exhaustive list. I only have 2 on here, but because I saw that there were so many products, I was like, okay, I'm gonna pick 1 or 2, and those are gonna be the ones I recommend. I can't keep looking at all the products out there and pick the 20 that are good. So this Elvet, you guys probably have heard of this one because I know they do a lot of marketing to veterinarians. And I think, oh no, they sell directly to clients as well. But this is a product that was studied at Cornell, so that's why this one is quite popular. And I like this product here. This is a paste for cats. So this makes it easy to dispense. And then this is just another company that makes CBD for dogs and cats, and they check all the boxes for me. Clean extraction, clearly labeled. They have this product called Centessa, which has 30 milligrams per capsule. That is a lot of CBD, and that's what you want. So, and the Elvet also has like, I think their large breed mobility chewable treat has 30 milligrams per chewable treat. Sometimes the products that you get in Petco or PetSmart, they'll have like 1 milligram per capsule, if that. So you need about 2 mgs per kg twice a day to have the desired anti-inflammatory effects. That is a lot of CBD. Again, especially when you're looking at products that only have 1 milligram per capsule. That's not going to do anything for anybody. So someone will say, oh, I tried CBD and it didn't work, but you're only taking 1 milligram a day. Well, of course that didn't work. You might as well just take Pepcid. So I don't just use this for arthritis. I will throw CBD at anything that's painful. And we had this dog, his name was Chaska. He is or was a 12-year-old male-neutered Malamute mix. We ask on our client intake form what the pet's favorite activities are, because I like to get to know them before I meet them in person. And Chaska loved car rides, he loved all treats, and he loved squeaky toys. And this was his diagnosis. Yeah, that is not a fungal infection. That is metastatic disease. And I had a consultation with this owner, with his family, and they were lovely people. But understandably, for this 12-year-old Malamute mix, she really, didn't think it was practical to do a bunch of stuff. And, as hopeful as I am about most of my cancer patients, this is bad. When you have multiple nodules throughout the lung, you have a poor prognosis. So I told her, this is a bad thing. We could try to find out exactly what type of cancer this is by getting a fine needle aspirate of one of these nodules so that I can, pick a chemotherapy or targeted therapy to use. And she was like, no. And I was like, okay, how about you try some CBD? And she was like, yes. And the next month, she came back to the clinic because she wanted more CBD for Chaska, that he was doing great. He was running around, acting like a puppy again, feeling fantastic. And then she came back 2 months later and wanted more. And 3 months later and wanted more. And I was like, okay, lady, you really need to bring this dog in. I need to do chest x-rays. I will do them for free. Please, please let me see what's going on in there. And she was like, no, I don't want to know. Just give me my CBD. And I was like, okay. So I think she kept coming back for about 6 months after that, which is just bananas. And I certainly wouldn't think that is a common response, but she came back for a while asking for her CBD for her Chaska. So CBD is one way to control pain. As we talked about in the beginning of this talk, a lot of us reach for tramadol and gabapentin and prednisone. And when it comes to bone pain, you absolutely should be using a multi-modality approach or multi-drug approach. Bone pain in particular is caused by several mechanisms of action. And so you can't fight that with carprofen alone. If you are comfortable prescribing an opioid, I understand the downfalls of that. But if you have an emergency situation, or maybe you're only going to be using it for a few days, or you're comfortable with it because oxycodone, it is a good pain reliever. 0.1 mg per kg twice a day is the dose for dogs. That is a very tiny dose. Pregabalin. Pregabalin is the next generation of gabapentin. It has way less sedative effects and way better pain relieving effects. And it only needs to be given twice a day instead of 3 times a day. The dose for pregabalin is 2 to 4 mg per kg twice a day. I start off at 2 mg per kg and I work my way up from there if I need to. I put budesonide on here because I sometimes forget about budesonide. I don't think general practitioners forget about it as much as I do, because I use Pred a lot. But for any sort of GI inflammation, budesonide might be a good idea. And like I said, with bone pain, you want to use a lot. And I explain that to owners. I'm like, look, I'm not just trying to throw a bunch of drugs for the sake of it, but when it comes to bone pain, we're looking at multiple mechanisms of action causing that pain. So we need to fight it with different modalities. And if families let me, I treat with a bisphosphonate, an anti-inflammatory, CBD if the dog will take it, sometimes an opioid, and definitely pregabalin. If you're not comfortable prescribing pregabalin because it is a controlled substance, go ahead and use gabapentin. Don't forget about amantadine. They're good drugs, but I'm telling you, pregabalin is way better. Okay, veggies. Why on earth would I talk about veggies? Well, vegetable and fruit consumption is inversely associated with cancer incidence and mortality in people. The consumption of cruciferous vegetables in particular is associated with the greatest inverse relationship. And this has been shown in dogs as well, that eating whole vegetables reduces their risk of cancer. Now, if I have a patient that already has cancer, which all of my patients do, I am very clear about the fact that I don't think feeding them broccoli is going to cure them, but anything that is going to help the immune system work for us and not be sleeping on the job, that's what I want to do. So the cruciferous vegetables contain the highest amount of a compound called sulforaphane. So this is a chemopreventive agent that reverses or inhibits specific molecular steps in the carcinogenic pathway. So it can save you from cancer. Sulforaphane started receiving a lot of attention about, I have 10 years here, but I guess it's been about 15 now, when it was discovered to be the most potent naturally occurring inducer of phase 2 enzymes in both people and animals. And phase 2 enzymes are what convert carcinogens to inactive metabolites. So that's pretty cool. And there was a strong inverse relationship between tissue levels of these enzymes and the susceptibility to chemical carcinogenesis. So sulforaphane is really cool. So how are you going to get sulforaphane into your patient? Well, like I said, broccoli and the cruciferous vegetables contain the highest amount of sulforaphane. Broccoli sprouts in particular have the highest concentration of sulforaphane. It's not always easy to find broccoli sprouts. They can be in the regular supermarket, in the like salad section where the lettuce is. Sometimes you'll see sprouts over there, but sometimes it's a lot of bean sprouts and no broccoli sprouts. The other problem with broccoli sprouts is they're quite bitter, and not all dogs are going to eat broccoli sprouts. Some dogs are just garbage disposals and they'll eat anything. So if you can find it, great, feed them a bunch of broccoli sprouts. What I tell my clients is that, the easiest thing to do is get some frozen broccoli, keep it in your refrigerator, and every time you make a meal for them, throw a handful of that broccoli in there. You can get fresh broccoli and lightly steam it yourself. That's fine. This product is by a local Seattle company. I don't know if they're national, but it's called Green Juju, and they have different formulations. Bailey's Blend is one of them, and Bailey's Blend contains, this is kind of like frozen soup. It's a broth. It has all just whole fruits and vegetables in there and this bone broth. So you kind of scoop it out like ice cream and mix it in with their food. The Bailey's Blend contains the most amount of cruciferous vegetables, which is why I've included it here. It is not inexpensive, but it is an option. And then Green Rover makes this product that is basically just dried broccoli, and you open this container and you're just hit with the smell of broccoli. So it's like powdered broccoli. Again, I think just, lightly steamed broccoli is best, but not all dogs will eat that. And for families who can do these extra things, these are just other ways to get some cruciferous vegetables into them. I know it's getting late. We are almost done. This is the last thing I want to talk about, glucans. So beta-glucans are soluble fibers that are found in bacteria, fungi, and yeast. These substances can increase the host immune defense by activating the complement system and also enhancing macrophages and natural killer cells. And natural killer cells, if you remember from vet school, naturally kill cancer. So way to go, beta-glucans. So how are you going to get beta-glucans into your patients? One way to do it is with this product by Real Mushrooms. There are other products out there. Like I said, I do my research, I find a product I like, and then I just stick with it. because I get tired. But if people bring me a product, then I'll take a look at it and I'll look at the ingredients and who makes it and blah, blah, blah. But I like this product. I think they make a good product. They use only the fruiting body of the mushroom. There's a little bit of debate as to whether or not that is the right thing to do. But when it comes to fungi, you have the fruiting body, which is the part that looks like a mushroom. And then you have the mycelium, which kind of looks like fibers or roots, but they're not roots because it's not a plant. But that white stuff that's underground. There are some that say that the mycelium is not where the beta glucans are, is not where the medicinal properties are, that you only want the fruiting body. Also, some companies will grow mushrooms on oats and then include the oats and the mycelium and the fruiting body in their product. Well, I know the oats are not helping. So real mushrooms doesn't do that. They only include the fruiting body of the mushroom. They do not include the mycelium or the growing medium. The mushroom immunity pet chews are probably what I prescribe the most because it's a chewable treat. Most dogs like them, and many of my patients are already on several pills, so I try to avoid more pills. But for dogs that don't like the chewable treat, it comes in a powdered form. It also comes in a capsule form. Now, I like the 5 Defenders and the mushroom immunity pet chews because this contains 5 different mushroom species as opposed to just turkey tail or lion's mane. And the reason why I like a multi-species supplement is because while there is a lot of research on PubMed about beta glucans helping in different situations, especially promoting immune system function, what I couldn't glean from the research was, well, which mushroom species, how much of it, in which species of patient, dog, cat, human, for which type of cancer, like what combination of that do you need? That I can't figure out. There's a little bit out there about turkey tail and lymphoma and hemangiosarcoma, but I mean, it's just a little bit and it's not overly convincing. So I like the 5 mushroom species. There is a little bit of information out there that cordyceps may help patients with melanoma. So I do sometimes use the cordyceps mushroom on its own as opposed to the 5 Defenders, but most of the time I'm reaching for that multi-mushroom species. Now, one other way to get beta glucans into your patient is by this product by Nutramax. It's called Immuquin. This is basically like a multivitamin and mineral supplement for dogs in a powdered form, dogs and cats in a powdered form, but it also contains beta glucans. They get their beta glucans from yeast. They've been seeing some really good results in cats with IBD with this product. So this is just one other way to get beta glucans into your patient. All right, Leslie, I am done. I want to thank again the Black DVM Network for having me tonight and for sticking with me for this very long presentation. Leslie and Rebecca have been nothing but wonderful to me, so thank you very much. Again, I am from Hope Veterinary Specialty Services. We do comprehensive vet-to-vet consultations for general practitioners who are doing the best they can to take care of their cancer patients in their clinic. So contact me if you need help. You don't necessarily need my help. You can do all this on your own. I know you can. And I hope this presentation has given you some good tips and tricks to take care of your patients.
Thank you so much, Dr. Rizzo. We appreciate it very much. Before people pop off, make sure that you send over your email address for your CE credit. And Rebecca is taking those, so we really appreciate it. I think this was a really enlightening presentation, and I hope everybody got something out of it, some little nugget that you can take back to your practice. And Dr. Rizzo's information is above, so don't hesitate to contact her with follow-up on this presentation, because it looks like you can use it day in, day out in general practice. So I think that's exciting. So everybody, thank you so much for being here. If you have questions, you can always reach out to us at info@blackdvmnetwork.com, and have a great rest of your late afternoon, early evening. Thanks so much.
Thanks, Leslie. Thanks, Rebecca. Thank you,
Bye.
everyone. Bye.
Bye.